はい、皆さんこんにちは。JSMO2025 で神戸に来ています。ですね、今年の神戸は非常に、ね、寒くて、凍えながらいろんなセッションに参加してるんですけども、今日は、ドイツからですね、アクセル・マスバーガー先生をお呼びしまして、彼はインターナショナルスティアリングコミッティングメンバーになってもらって、このJSMOの中医オンコロジーを盛り上げてくれてるんですけれども、ちょっとこの隙間時間にですね、彼を捕まえて、前立腺がんの薬物療法に関する最新の話題についていろいろインタビューしたいと思います。Hi Axel, welcome to our program.
Yes, konnichiwa from JSMO. Thank you for inviting me. Thank you.
So we are going to talk about systemic therapy for metastatic prostate cancer,
Yes.
especially MCSPC castration sensitive prostate cancer.
Yes.
So now in Japan we have several regimens, including the doublet and the triplet for MCSPC. But in terms of triplet, only darolutamide ADT docetaxel is available in Japan.
Yes.
And so one triplet and three doublets are available in Japan.
Yes.
How about in Germany?
Yes. Dr. Kitamura, as you know, we have this similar situation in Germany. We, as urologists, also treat metastatic prostate cancer, which is unique for our two countries. I think in other countries like US or France or Spain, it's only within the hand of you, the medical oncologist. But I think here we have the same situation. So we have to decide on triplet with darolutamide or a doublet with apalutamide, enzalutamide, or abiraterone with the prednisone.
Yeah.
Those are, I think, the options right now. And we have seen RNO data from darolutamide doublet therapy, but it has not been approved in Europe yet. Japanese situation?
Not yet.
So we are waiting for that. Then we have a fourth option for doublet, but it's always difficult to discuss, and we discuss with the patient, and we first look at eligibility criteria, if the patient is chemo eligible, most are, and then we look at the disease volume and risk. If it's high volume, high risk, de novo, and visceral disease, I think then definitely we have to discuss about triplet therapy. And if it's synchronous and recurrent disease, definitely also a doublet is an option. But also, like it's not a clear cut. Also, when looking at the doublet trials like Titan and Arches, they were 60% high volume or high risk. So it's also an all-comer situation for doublet. So it's really something you have to discuss with the patient and the pros and cons, or with the MDT.
I see. Do you consider the volume criteria, high volume versus low volume, and metaclonus or synchronous? So because the NCC guidelines proposed 4 groups. Exactly 3 groups.
Yes.
High volume synchronous, high volume metaclonus, low volume synchronous, and low volume metaclonus. Do you consider the criteria?
Yeah, I think we need an update, because Chris Sweeney introduced the volume criteria 10 years ago, the charted trial, and I think he's working on an update as well. And then we have the latitude criteria with high risk, which is, at least for Europe and Germany, within the label of abiraterone. So you need to have a high risk situation to give abi. It's not an all-comer drug in MHSPC, at least in Germany. So we still have to do it. We should do it. I torture my residents to do it in the referral letters and so on. But I think we need an update in the future, maybe with the ctDNA or genetic markers in the future, more precision oncology. I think that would be the future, and then how to treat.
I see. And then when do you order BRCA mutation examination?
Yes, I think there we have different labels for the PARP. In Germany, we have 2 PARP combination triplet olaparib and abiraterone and enzalutamide and talazoparib for a broad population. All cover label. Yes, from where we just saw at ASCO GU the overall survival benefit, more than 8 months benefit for the combination, and also regardless of the HRR status. So in Europe, we have regardless of HRR mutation. I like to test. So I know in Japan you need BRCA, I think, BRCA1 or 2.
Yes, exactly.
I want to test, and I test once we have progression on MHSPC treatment. So when I start with apalutamide or do a triplet, and I see the PSA is rising again, then I submit for molecular tumor board, and then I want to see the marker, the whole panel, MSI high, P53, some alterations, HRR mutations. I think then it's very important to see.
Okay, so do you mean that the test is for comprehensive cancer general profiling examination, right?
So depending
only for BRCA mutation, not only for BRCA mutation, but also MSI high.
So yes, we do test.
Yes,
we do test in the panel, but also it could be for this precise question. You could also just test for HRR mutations like the known BRCA1, BRCA2, because this is the ones where you have the strongest signal for PARP inhibition.
Right.
And we haven't seen, I think, the TALAPRO-3 trial data. It's not published. Where in MHSPC, the EVO-PAR trials from another company is just investigating another PARP also in MHSPC. So exciting time, but then I think we also need to test.
Okay. And I know that in Germany, the nuclear medicine is very common.
Yes.
More common than other countries. So, do you routinely perform the radioligand therapy for CRPC?
So this is, as you said, in the hands of the nuclear medicine experts. So we don't give it, but we recommend and we give our patients to their colleagues' hands in case we have progression after triplet therapy. So if progression after docetaxel and ARPI has been, then the option is carboxytaxel, PARP, or radioligand therapy like Pluvicto.
It's just docetaxel, right? Or not before docetaxel.
It's just after docetaxel. Yes.
Okay.
So we've seen the PSMA4 and the splash data with PFS benefit, but no overall survival benefit. But it's not approved yet. So approval is post-1 RP, post-1 taxa.
Okay. How about after the triplet treatment for HSPC and PD? And the carboxytaxel, or you can use
you could use both options.
Both options. Okay.
So because then it's post one taxan. You could use it. It's always safe to make an MDT decision, and then you are safe with the payers. So we do an MDT decision and say, now radioligand therapy, and then submit. And then there's a question whether radioligand therapy or carboxytaxel, and we do a PSMA scan, and if we have no signal, 15%, we go for carboxytaxel. If we see PSMA positive and a high SUV, it's more in radioligand therapy.
I see. It makes sense.
So I have one more question. So in the future, so what do you think about the T-cell engager for prostate cancer?
Well,
I'm very interested in your
I'm biased because we don't have a marker yet. We have T-cell engager trials right now. I'm also involved in one, so we don't know the data yet. It's exciting. Also, we saw the data phase 1 at ASCO on EZH2 inhibitors, Mevroprostat, at ASCO GU, which is the first epigenetic target, which is quite interesting. We saw at ASCO GU, and it's a phase 3 trial looking at that right now. So we have biodegrader, we have the OMD substance, the CYP11 inhibitor, which is investigated in the Omaha 2 and 3 trial, looking at MCRPC last line. So there are like a handful of interesting mode of actions, but I have no glass bowl to know. This would probably influence the stock exchange if I would know. So I don't know about the outcome, but those what you mentioned are very exciting.
じゃあそうですね 先ほど北村先生がおっしゃったみたいにこれ隙間時間でなんと今からアクセル先生また次の会議に行かなきゃいけないみたいなので、今日はこの辺にしたいと思います。Thank you for Axel。
ありがとうございました。
ありがとうございました。
Thank you. Gentlemen.